Hello, everyone. Today, in my capacity as one of the three assistant editors for the RHM Journal, I'm interviewing Berkeley, Franz, and Dan Skinner on their essay, From Patients to Populations, Rhetorical Considerations for a Post-Patient's Compliance Medicine. And just to introduce them, Berkeley is a medical sociologist whose research and teaching focus on community-based philosophy, social theory, and health policy. She has worked both domestically and internationally on community-based research projects aimed to improve health outcomes and develop health care services guided by local perspectives. Dan is a health policy professor and is the author of numerous articles on politics and healthcare, published in journals such as the Journal of Health Politics, Policy and Law, the Journal of Medical Humanities, the Review of Politics, and Public Administration Review. Among their many health and medicine-related publications, Franz and Skinner are currently editing a volume titled Not Far From Me, Stories of Opioids in Ohio, which is under contract with the Ohio State University Press, and are working on a book titled Medical Urbanism, Hospitals, City, Neighborhoods, and Community Health with the University of Chicago Press. Both authors teach at the Heritage College of Osteopathic Medicine at Ohio University. Welcome, Berkeley and Dan, and thank you so much for agreeing to be interviewed.
Thank you.
Thanks for having us.
Great. So the first question I have for you about your wonderful essay that will be in the second issue of the RHM Journal is, Dan, you are a political scientist by training in Berkeley. You're a medical sociologist. So can you tell us a bit more about how you came to rhetoric in general and how you came to the rhetoric of health and medicine specifically?
I guess I'll start. For me, this focus on rhetoric goes back to my doctoral dissertation, which is another book that I'm working on that will hopefully be finished soon, which is really on the rhetoric of medical necessity. That's actually the title of the book, and the book is, to some degree, it's a work of political theory and a work of rhetorical analysis. In that book, I'm really looking at how the rhetoric of necessity, of medical necessity, is shaped through political debates. So I look at, for example, mental health and medical necessity in terms of what gets called necessary, what is not, looking at reproductive debates and looking at medical marijuana debates. So for me, this goes back to the way I really got excited about political theory in the beginning, which, as RHM readers know, our common point there would be somebody like Aristotle, right, and just thinking about the role of persuasion in politics. So for me, this has been a long project of being interested in this. And then, of course, coming through the RHM world, Judy Siegel's books, in particular, be no surprise to RHM readers that was an influence.
Oh, definitely. Yeah, she is huge for all of us. So that makes total sense. Great. And your next book sounds great, too. So looking forward to reading that.
Thanks.
So I would say I'm a bit more new to the rhetoric of health and medicine. There's a lot of overlap between this and sociology in terms of studying, healthcare organizations and how language and practice settings have changed over time. But I would say that in sociology, there's a large emphasis on theory, but not so much on rhetoric itself. So I was drawn to that in particular and thinking about not just studying, how organizations and medical care have changed, but actually talking about the language and how that has kind of a politics behind it.
No, that makes great sense. Good, thank you. Okay, so you both are teaching at the Heritage College of Osteopathic Medicine at Ohio University. Can you tell us a bit more about your work with medical education?
Yeah, so it's an interesting role to be in a medical school. It's always interesting to teach students that don't have the same degree that you have, don't have the same background, but it's also an incredible opportunity to influence a real profession in terms of having a practical outcome. So it's interesting taking some of the theory of the work that we do and try to put it into practice in some way. But it's a challenge to do that as well. And so we're finding ways through lectures, through small group facilitation, to help doctors understand how the medical profession has changed, how it continues to change, as well as some of the real, critiques of doctor-patient interaction, for example, or the healthcare system. But it's not a traditional role. We don't teach traditional classes. There are no instructors of record. So we interact with students in a much more informal way, I would say, than we would be used to teaching, for example, in a College of Arts and Sciences or something like that. And so we're kind of relearning how to integrate our own expertise into this very different kind of discipline without owning a lot of time with students because we don't have traditional classes in that sense.
Interesting.
I would say, as social scientists, Berkeley and I, and we're members of an interdisciplinary department, Department of Social Medicine. So, we have a bunch of colleagues who really run the gamut in terms of their disciplinary backgrounds, which is something that RHM is a real home for, a bunch of people who just fit together because they fit together and for no other reason. They have common interests. I will just say that, as RHM readers know, the typical medical student doesn't have a deep humanities background, isn't going to be well versed in a lot of what animates RHM. So I think that's one of our missions, is really to not just get students to think about their rhetorical practices in terms of like patient communication, how to deliver bad news. I mean, that's all part of it, that kind of thing. But more generally, just to really appreciate the depth of, the power relationships, the way in which language and conceptual thinking, is at the root of what they do.
Okay. Excellent. I like what you said, Berkeley, too, about it being such an opportunity, because many of us that work in RHM, we teach rhetoric students, and so we don't always have the opportunity to sort of reach people who are going to be working directly with patients. So that is a wonderful opportunity. Okay, so back to your essay. Your essay, which again I really enjoyed reading, it uses rhetorical principles to show how linguistic shifts meant to mitigate the, quote, deep ethical problems of noncompliance discourses on quality of care ultimately fail through a sleight of hand. They only reify the power dynamics they seem to challenge. You call this rhetorical repackaging. And for listeners who have not yet read the essay, you show, for example, how the shift from compliance to more seemingly respectful to patients' terms like concordance and adherence are not able to truly perform the conceptual shifts they are designed to deliver. You call this a rhetorical shell game, great coinage. From your other very formidable body of work, do you have other examples of this failure of terminological changes to impact actual material epistemological change?
Well, there's two things I want to say. The first is that reworking the rhetoric doesn't always guarantee reworking the material relationships. And we live in a society with that often has a thin, my interpretation, a kind of thin liberal shell. So people learn to not use racist language, or they learn to, maybe not be ableist in their discourse, or learn, because of sexual harassment training or gender training, that they learn how to speak in a certain way. Right. But it doesn't always affect the actual more subtle dynamics when you're in these spaces. And I think it's that disjunction between language and materiality that you see this happening a lot. I think race is a big one. Absolutely. Really learning how to alter how we handle, racist patient scenarios or institutions that, where sexism has just been rampant for so long that any number of trainings is not necessarily going to really transform the place. It's a long process. So those are the kinds of things I think about, that we do have this kind of push and pull between reworking language, which is a good thing. It's an important thing. And I'm glad that people stop using certain terms and are maybe more aware of it, but it doesn't always guarantee institutional transformation in a deeper sense.
Yeah, well said. Good.
And I have a healthcare example. In fact, we just had a paper that was just published on this topic, and we talk about this in this paper too, about this important shift to population health that we're seeing in medicine right now, where we're focusing less on patients as individuals and more about communities and larger groups of people in terms of being able to prevent things, or also just seeing upstream factors that affect whole groups of people, for example, like poor housing or racial discrimination or things like that we know are really important in terms of driving health outcomes. So medicine talks, a lot about population health and about the way that things are changing in terms of focusing less on physicians and more on this prevention work. And we see new requirements for hospitals, which is what we're working on. But what you see in practice is that people have adopted this new language, but they haven't really adopted the philosophy of starting to think about community engagement, for example. And so we just published this paper about how people use this language of population health, but they use it really differently. So, a very small amount of hospitals and physicians really think about it in terms of community-based engagement, prevention. A lot of them think about it as just reworking their existing patient populations. They don't really move beyond that. They think about just managing their kind of existing population of patients and not really getting outside of the kind of clinical sphere in terms of prevention or starting to engage some of the social aspects of disease. And so I think there's a real kind of challenge in terms of shifting towards that perspective. Even though the language has already moved in that direction, there's still a lot of kind of left behind in terms of older clinical models.
Yeah.
I think that there's a concern. I know we have this, as a political scientist, I have this concern that people not see changes in rhetorical structures as political victories. So, for example, the idea that, that people are talking in a certain way, that they're using adherence or they're using concordance or whatever, that might actually be worse than just using the language of compliance and wrestling with it, because it reminds them that they're not out of the woods. And I think we do worry about this idea that, okay, we've trained people and they're speaking in a certain way, and that they maybe think that as a result they've freed themselves of certain power relations that might actually be more intense because they're not being observed anymore, because everybody thinks again that they're out of the woods.
And that's one of the most important things that you all are sort of contributing with this piece, I think, is helping people to think more about, as you say, that these linguistic changes don't always translate to actual progress. So really, really good. Okay, so the next question I have for you is, your essay argues that shifting from the patient-physician dyad and compliance to a population and community health framework would make the kinds of changes that renaming compliance other, seemingly less threatening terms cannot. That said, you're careful to point out that discursive shifts in scholarship do not always reach in the trenches healthcare workers. So as educators in a medical school, how do you promote post-compliance framework for your students? And I know you did mention earlier sort of like that, the tricky space you're navigating, not being an instructor of record, not teaching traditional courses, and that kind of thing. But do you have any sort of day-to-day pedagogical practices through which you're pushing this post-compliance framework?
We had read all or as much of the compliance literature, and it's a fairly vast literature at this point.
Yeah.
We were really immersed in this and kind of struck by how many people had been working on this, and for a long time too. And it seemed like a consensus had developed that compliance was not an effective discourse or an appropriate or ethical discourse. That said, so I was talking to a clinical colleague, and I told them what we were working on, and this person said, "Oh, I must not have gotten the memo that compliance is not allowed anymore."
Oh, wow. Yeah.
And it really did strike me. That scholarly literature doesn't necessarily mean that it's going to affect clinical spaces, especially because clinicians do read literatures, but they're not reading this literature.
Right.
But the other one was that in some cases it's just, it persists much more. Berkeley and I, we'll be in presentations and things, we'll text each other. We hear compliance, spoken again and again and again in these very uncritical ways, and it's actually kind of striking to us how it's still lodged in so many discourses, despite being so discarded or so critiqued in the RHM kind of literature.
Yeah, definitely.
It's almost seen as being, a lot of clinicians push back on being politically correct. It's seen as like, a lot of clinicians will say compliance, oh, I guess I should have said adherence, or I should have said concordance, almost as a joke, as thinking that the language has shifted, but nothing really else has changed. Like they don't necessarily really believe that it should have ever changed, because there still is this physician centricity at the heart of medicine and the doctor-patient interaction. So I think it's hard to shift the culture in terms of our actual efforts to, work with medical students to get them to understand why it may be problematic. I think for me personally, as a sociologist, I'm really influenced by data that suggests that this, doctor-patient interactions really don't matter in terms of improving patient outcomes. Clinical care doesn't matter as much as we thought it did. It's about 10% of what we know drives health outcomes. So really teaching students about, you care a lot about health outcomes, and you really need to think about more than your, small interaction with a patient. You have to look outside of that. You have to look at the social determinants of health. And doing that is necessarily going to really alter the kind of model of compliance, because it's really going to kind of complicate that idea. But even also it's going to challenge the, focus historically on this very small aspect of clinical medicine, and instead of focusing on a whole host of other environmental or social or historical or whatever factors that seem to really matter when it comes to improving health. So for me, that kind of pushes them in a direction of really kind of questioning compliance, but also questioning the clinical model in general.
Wow, that's brilliant, because you're almost deflating their ego a little in the process to be like, look, your actual interactions with patients, not so much, but all of these other things, yes, right? No, that's great.
To have good interactions with patients, that's an important part of it too.
Of
but
course,
yeah, it's
of
not
course.
everything. Yeah.
But helping them to see the bigger context seems like a really smart way. So that's great.
Yeah, but these are hard conversations to have, and it's part of our job as social scientists to push back on some of the physician-centric approaches. I mean, it's kind of amazing. We have these discourses that are, threaded through medical education now, patient centricity, whatever it might be. But at the end of the day, lots of physicians they became med students and then physicians because they wanted to make decisions.
Mm-hmm.
And they're wrestling with the fact that these decentralization models are in cooperation, collaboration. Sometimes it means that they're not the quarterbacks or the deciders or whatever metaphor you want to use here. I know Judy Siegel does a great job sort of giving us a list of those,
Mm-hmm.
but dislodging them of that a little bit is really hard work. So I just have to say the second point I just want to make is that, compliance seems to persist in large part as a frustration point because there's so much focus on malpractice and legal vulnerability. So a lot of our students and our clinical colleagues will say, look, I'm going to be sued if they don't do what, that it puts them in a vulnerable legal position if patients don't do what they told them to do. So really, it's not just about doctor-patient relationship and compliance. It's also lodged within larger rhetorical structures like legal rhetoric, medical rhetoric.
Mm-hmm. Absolutely. And I have to say, I think as a medical educator, I've learned something from my students and my clinical colleagues in that I have a little bit more empathy for their position in terms of understanding compliance, just because working with people can be really challenging. And sometimes you've had all this education, what's good for a patient, and you feel like you really want to help them, and the patient doesn't, want to listen to you. I feel like over time, sometimes the physicians really get burnt out by that. They feel like they have something to offer and they can't offer it. And so I do feel like I've learned a little bit just from working in a medical school in terms of what it's like on a day-to-day basis, and what you've been trained to help somebody and then you're not able to. There is a little bit of frustration, even if they're not quite understanding the inherent problems in that. I think it's a real opportunity just to kind of learn a bit more about the clinical environment and relationship, and some real kind of tensions within that, and just that people are really, hard sometimes, and that, for a variety of reasons.
Yeah.
But it's important to kind of recognize the kind of relational challenges that are part of the clinical encounter that I appreciate a bit more, I guess, being in this environment than I would have if I hadn't been.
Absolutely. I think that that's another compelling part of your positionality as researchers and writers, is that a lot of times if you have someone coming from a purely humanistic perspective and they've never interacted more than just, say, going to a physician themselves or with a family member, that they don't have that sort of like empathy for the position of the physician, that they're not like just like unilaterally like bad people or out to get patients or out to be like the heavy or something like that. So yeah, that's well said. Good.
Yeah, I certainly wouldn't want anybody to interpret this whole critique as being, just simply against physicians.
Oh, no.
Really, it's about diagnosing a whole pretty broad power dynamic within medicine, I think.
And I think that definitely comes through, and I hope that other readers agree, but I definitely saw that and just thought that the specificity of the argument is another thing that just makes it a really strong piece. So. Okay, so the next question I have for you is, you argue that linguistic and material changes must work in tandem to intervene effectively in the problems inherent in noncompliance discourses and their effects. You offer lay community health workers and health advisory boards as examples of community-level health organizing, as examples of the era of population health and its potential power to disrupt power relations. Do you have other examples you would be willing to share, even specific ones from your other field-based research?
I have one that I would share, and there's something that I'm interested in and I've written on a little bit, is the attempt to kind of open up the medical record to make it a little bit less doctor-focused. And so this can work on an individual clinical level, but it also can work on a community-based level in terms of kind of shifting the communication streams between physicians or hospitals or any kind of medical professionals and communities. But the idea would be that, any kind of medical encounter or health services encounter should be first of all, a lot longer than it typically is right now. Most clinicians have on average 7 to 10 minutes to with the patient. There's not a lot of opportunity to understand the patient's background, for example, their history, their environment, their religious life, or community support, where they live, things like that. So opening up an opportunity for patients to share a lot more about where they're coming from, which would really kind of contextualize why or why not a patient may not take a medication, or may not exercise, or may not make it to their appointments, right? There are a lot of the clinical practices that we're affiliated here have a 3-strike rule. If you miss 3 appointments, you can never be a patient there anymore. Wow. And they don't offer opportunities to understand a little bit about what's going on. And so these open records not only allow for better communication between doctors and patients, but they also allow for better practice design, and for health services that really meet the needs of communities that live in an area. So I think there's a real opportunity to open up more communicative kind of spaces, whether it be for a doctor and a patient, or for a community.
No, that's a great example.
I would just put in a quick plug for our book on hospitals and communities, which we're writing with our colleague John Wynn at University of Massachusetts. Really, the premise of that book is, or the kind of the way we're approaching it methodologically, is trying to look at ways in which hospitals can rethink kind of who they are and how they interact with communities. And they may, for example, think that they're really open to the community, but then if you talk to communities, you find out that they're not at all, or not perceived that way anyway. Or even one of my, the most amazing things that I kind of had to wrestle with was hospitals who literally, the neighborhood would be across the street. And the neighborhood would say things like, "We feel so distant from the hospital. We feel so," even geographic and geospatial terms. Just the lived experience of walking streets can oftentimes be quite different than how hospitals think when they're looking across the street at these places and saying, "We're right here. We keep inviting you to things, and you never keep coming."
Interesting.
But because the community doesn't necessarily feel that closeness.
Yeah, right. Well, you've convinced me. I'm definitely going to read your book when it comes out because, like I said, I just loved your article. So I know that you're both really strong thinkers and writers. So, okay. So thanks for bearing with me. I've got one more question for you, which is, what's next for your work with post-patient compliance medicine? And I guess you partially answer it by talking about your book a bit. Are there other concepts that you're working out that complement this work that you want to talk about?
I wanted to just say, Berkeley and I have a pact to not start any new projects for a while because we're extended. So take what I'm saying with that grain of salt.
Okay.
But we have talked throughout just about how great it would be to be able to do interviews and just to listen to clinicians talk about compliance, to do discourse analysis of some sort. But to really get some empirical, fragments to work with, because we walk around the halls of our institutions, and we know, in other institutions, you hear this language all the time. It's in a kind of Wittgensteinian way. It's sort of just like people just say it. They're not saying it critically. They're not saying it to be disruptive or to be resisting an entire literature. They're not, counter-revolutionaries or anything. Right. But the language persists. And I think that being able to listen to how it's used would tell us more than we're able to accomplish in a theoretical piece. I think we flagged that maybe at one point that would be something we'd like to do, but that would be the dream for a next step for this. So it's not a different concept; it's a different way into thinking about compliance.
That's brilliant, and I would love to see that work. Although I admire your pact because you do have voluminous scholarship happening, and it's very, very impressive. So I don't doubt actually that you are a writing team that will get to that next project. So that'll be exciting to see. So this has been so great. When Lisa and Blake passed on your essay to us and I read the title, I was excited. And then when I read it, I just kept every page. I'm like, wow, these two are amazing writers. This is so well researched. This has so much great literature covered in it. And I just find you both really impressive. And I appreciate you taking the time to talk with me.
Thanks for saying all these nice things.
Yeah, that was a lot.
It's true.
Yeah,